Good morning and welcome to the 90-90-90 Targets Update. My name is Dr. José Zuniga. I'm president of the International Association of Providers of AIDS Care, or IAPAC. With UNAIDS and ITPC, we're honored to host this 90-90-90 Targets Update to provide an overview of challenges, opportunities, but as important successes that have been achieved over the last year in maintaining continuity of HIV care within the context of COVID-19. I'd like to give my thanks to our partners as well as to Gilead Sciences and ViiV Healthcare for sponsoring the 90-90-90 Targets Update. And with that, would like to introduce our panel, which has lost time recovering from COVID-19's impact on the global AIDS response. Over the last several months, IAPAC's been conducting a survey of clinicians worldwide, asking them key questions about the impact of COVID-19 on HIV responses. Among the key outputs from the survey are that 88% of clinicians from 75 countries are now managing COVID-19. Clearly, the surge of ID and other HIV-treated clinicians was needed to manage the wave of coronavirus infections in these countries. But concerning to us are the significant disruptions in various HIV services, including 35% of our clinician respondents indicating disruption in antibody testing, 29% in ART initiation, 31% in relation to PrEP initiation, and 45% in relation to mental health. What COVID-19 has represented for us is a looking glass to see the resilience, but also the fragility in HIV responses, not just in the global South, but also in the global North. With that, I'd like to thank my illustrious panelists, public health leaders, all in their own right, and introduce the first of them, Dr. Angeli Achrekar, Principal Deputy U.S. Global AIDS Coordinator, who will speak to PEPFAR's perspective on mitigating the impact of COVID-19, including by ensuring continuity of HIV care for people living with HIV. Angeli?
Thank you very much, Jose. And I want to thank IAPAC for convening us to really talk about this important issue. I bring with me Ambassador Birx's well wishes as she is out there fighting COVID-19 domestically as we speak. It really is an incredible time to be focusing in on this topic and ensuring continuity of care. So I'm really privileged to talk about PEPFAR's perspective on this and what we've been doing over the past several months and partners with many of the panelists here, as well as partners all around the globe. So first, let me start with the incredible progress that has been made. Over the past 17 years, the US government, through PEPFAR and its substantial contribution with the Global Fund and with partners all over the globe, multilateral partners, governments, implementing partners and communities, we've made incredible progress. What you see here is PEPFAR's program results for 2019, at the end of 2019, with over 15.7 million men, women, and children on life-saving ARVs. We are seeing country after country, community by community, through our population-based surveys showing incredible progress toward UNAIDS 90-90-90 goals, really countries getting to a point of epidemic control. That said, COVID-19 has really affected and continues to affect the global HIV response. We have been doing every single thing in our power through the PEPFAR platform across the countries to really ensure that we are facing the impact of COVID-19 on the program and on the global response in 4 key ways. First, ensuring continuity of care for people living with HIV. Second, leveraging the PEPFAR-supported health systems and infrastructure to both serve HIV, of course, but also in ways that we can respond to COVID-19. Third, reducing exposure of staff and HIV clients to healthcare settings that may be overburdened and/or sources for potential exposure to COVID-19. And finally, really providing flexibility for the PEPFAR program and how to optimally serve the clients that we are serving in areas affected by COVID-19. And I'll talk a little bit about each of these. Aligned with PEPFAR's programmatic focus through its country operational plans to really focus on the client, patient-centered care, quality care, we have been aligning our COVID-19 response to really make sure that we are escalating convenient client-centered services throughout. And what this really translates to is rapidly really moving out on interventions to protect the gains with an emphasis on convenient client-centered care. So in the context of COVID-19, really ensuring that the gains that we have made as a globe continue for HIV clients and the beneficiaries of the programs. We've been moving out and maximizing retention before lockdowns, really rapidly scaling up multi-month dispensing to ensure continuity of care, decentralizing drug delivery at in various ways, and using virtual platforms like no other to communicate with recipients of care. Again, ensuring continuity of care for people living with HIV is a primary concern of ours and focus of ours to really ensure that those 15.7 million people that we have on life-saving treatment are maintained on that service, as well as maintaining virologic suppression. I'll talk a bit more about this in a second, related to 3 and 6 month multi-month dispensing for the clients. But I'd like to just note sort of overall that the challenges that the people living with HIV are facing globally are really exacerbated during COVID-19. And we're seeing this across the board. Stigma and discrimination continues to be a concern. We know the need of self-protection and social distancing. It's very difficult when we think of high density areas, informal settlements, overcrowded cities, public transportation, multi-generational households. These are issues that are exacerbated in the context in which we're working and implementing. Of course, the secondary outcomes as well: lack of clean water and sanitation, food insecurity, economic considerations are real and pervasive. We believe that the response needs to prioritize a human rights approach, really centering on empowerment of communities and people living with HIV themselves. And we've been working together with our partners, our multilateral partners and governments around the globe to ensure that this happens. I'll focus a bit on some of the key interventions that we're rolling out with governments, with multilateral partners and the communities themselves. This slide shows the share of PEPFAR-supported countries with national policies permitting both 3-month and 6-month multi-month dispensing. And what we're seeing here is that countries are actively moving out on both 3 and 6 MMD. We've seen actually in the last 3 months alone that 22 countries have changed policies permitting multi-month dispensing and loosening eligibility requirements for multi-month dispensing, which has really been a critical intervention for ensuring continuity of care. What you see here are some specific country examples related to MMD policy changes that really spans some minor loosening of the policy, but again, just really ensuring that across the board, not just at the national level, but all the way down at the regional, district, facility level where the patients are served are having access to multi-month drugs. Decentralized drug distribution. This is something that we've also been scaling up across the board and really looking at different and new venues to really support clients where they're at. Home delivery has picked up, community pharmacies, automated dispensing, lockers, and other facilities like that. alternative pickup points within the communities that are closer to where clients are. Community centers, other locations like schools where children may not be in session because of COVID-19, but utilizing locations like that to facilitate drug delivery. I want to emphasize also that that we need to continue our commitment to key populations specifically during this time. There are specific nuances related to the programming, particular safeties that we're trying to ensure occurs across the program. So again, this is a critical area. This population is critical to us, and we have been working hard to really ensure that we are meeting their needs as well on the various policies that I described before, but also on particular challenges and discrimination that they are facing. One of the critical aspects of the work that we're doing in implementation globally really relates to how we are able to utilize the PEPFAR supported platforms that exist now over 17 years of work. This is capacity that exists in countries themselves, systems and infrastructure that exist that are in place for HIV, but able to be leveraged and being leveraged and utilized for other outbreaks like they have in the past, H1N1, Ebola, MERS, SARS, others, but now specifically for COVID-19. For example, over 3,000 labs that exist on the continent of Africa, 165 of those are accredited, and 28 national reference labs that exist because of this support. The 300,000 healthcare workers that exist on the continent, or around the globe rather, that are being leveraged in certain ways, nurses, clinicians, community health workers to help support the response. And just, again, PEPFAR continues to support these health systems and infrastructures. Annually, we invest nearly $1 billion to continue the support for the strengthened capacity that exists in these countries for surveillance, for laboratory, that facilitate a public health response. And as I mentioned, it is this robust capacity and surveillance system that exist that are now being leveraged to diagnose, prevent COVID-19. I was just off a call with the Cameroon program. Again, clear example, country by country, how the PEPFAR supported platform and the capacity that exists in countries are really being leveraged to both serve HIV as well as COVID-19. I'll end by just stating that over the past several months now, we have been issuing technical guidance to the full PEPFAR program across the countries, the 54 countries, that is on our website. We update this guidance twice weekly. We post it on our website. We're really trying to adapt to the real life situations that's occurring, that we're hearing about minute by minute, day by day, to really respond to the challenges to ensure continuity of HIV services in the context of COVID-19. So I'll stop there and thank you all for your time.
Thank you very much, Angeli, and please send our regards to Ambassador Birx, who we all know is doing the very best she can with the significant epidemic of COVID-19 here in the United States. With that, I'd like to introduce our next speaker, Dr. Meg Doherty, who's Director of the Department of Global HIV, Hepatitis, and STI Programs at WHO. She'll speak to WHO's work to maintain essential health services in the context of COVID-19 and HIV.
Okay, thank you very much. And I'm so pleased and give thanks to IAPAC, ITPC, and UNAIDS for inviting WHO to this important session. And like Angeli, I'm going to walk through what WHO is doing to address both HIV and the COVID infection, but really now moving forward in terms of how are we going to rebuild better and maintain the services that we have. Pardon me. So we know right now, as of this morning, that we have over 10.2 million confirmed cases of COVID-19 and over 500,000 deaths. And you'll see on these images that it's being driven by new infections occurring in the Americas, but we're also seeing resurgence of COVID infections around the world, and certainly in Southeast Asia and in places in Europe and around the world where we're starting to see where we're releasing some restrictions, but having to go back on restrictions as we see new infections popping up. So according to our epidemiology and our DG, we are nowhere near the end of this pandemic, and we have to understand that we're going to be living in a new normal. And what is that new normal, and how are we at WHO, along with our other stakeholders and partners, trying to work forward to maintain the gains we have? We know that we've done some modeling. UNAIDS, WHO, and 5 modeling groups came together to look at what the impact would be if we had a 6-month disruption of antiretroviral, either at 100%, at 20%, at 50%. And at the worst case scenario, we could have 500,000 excess deaths in sub-Saharan Africa, bringing us back to 2012 levels of death and really reducing our gains. This also can be seen in these modeling efforts in TB and malaria and many other diseases. So we have to work together around what are those joint person-centered approaches so that we can reduce and mitigate some of these onward effects of COVID-19. So part of one of the work that we're doing at WHO is trying to understand also, is there a particular relationship between HIV and COVID-19, where persons living with HIV, are they more at risk or less at risk of acquisition and or poor outcome? And on both sides, somebody who is living with HIV and has an immunosuppression could be at increased risk. They could have an increased risk because of the other infections they live with, whether comorbidities of diabetes, hypertension, etc. On the other side, some data coming from the SARS era and the MERS era showed that perhaps lopinavir/ritonavir showed some benefit in reducing either acquisition or reducing the effects of SARS and MERS. So thinking that perhaps the immune effect of antiretrovirals and or the immune decreases with HIV could protect somebody living with HIV. But what we've seen over the last 3 weeks, it just required a bit of time to gather some of this information. And a report out of sub-Saharan Africa in the Western Cape of South Africa showed that people living with HIV had an independent increased risk of death due to COVID. And when we look at that data in terms that are simplified, that would mean out of 100 people dying of COVID, 12 of them would have had HIV. But certainly the major driver of death for amongst COVID patients are really those with hypertension, diabetes, and or kidney disease. But we have to keep an eye on this and ensure that we keep people who are living with HIV on their medicines and ensure that we maintain that supply chain. So what do we know about the treatments for COVID? Unfortunately, it's looking like through the most recent trials that lopinavir/ritonavir is not going to be a big winner. And so even though there are ongoing trials looking at whether tenofovir and 3-TC, other medicines that people living with HIV take, whether those could have some benefit of either postponing infection or protective effect, currently the lopinavir and ritonavir trial of recovery have stopped their arm, but the other randomized controlled trial, Solidarity, continues. So the jury is not fully out yet on our antiretrovirals. We do know that right now hydrochloroquine and hydroxychloroquine are not recommended, but we have some positive information coming from remdesivir, low-dose dexamethasone, and anticoagulant therapy. I think now we just need those clinical trials to run their course, and hopefully we'll see some silver lining coming out of all of these medicines, because we also know we need to wait until we potentially have a vaccine, and that could take a bit longer. WHO has also, like many of our partners, been doing regular surveys about what are the disruptions. And we focus here in this slide on what are the antiretroviral disruptions looking like. Green is no reported disruption at the moment. Yellow is at risk. and red as disruptions. So you can see we're already starting to see across the continent of Africa and Asia disruptions and risk of disruptions. This is another survey done by WHO looking at other disruptions of general health services across the world. And what we see is the disruption for HIV and antiretroviral are running around 33%, but bigger disruptions are seen in routine immunization up to 70%, family planning, and certainly antenatal care. And these are also important for people living with HIV because these are important entry points. So we know that people are not coming to services and that we have to get those services back up and running in a safe manner. From the GAM data coming out for 2019, and very similar to what was reported by Angeli, is almost all of our countries have adopted a policy for multi-month prescription. But on the right-hand side, you'll see that most of them have not yet fully adopted a 6-month strategy. More of them are adopting a 3-month strategy. And what we're seeing from our regular weekly reports from countries that have moved to 6 months are now needing to revert back to 3 months or 1 month because their stocks and their central stocks are getting to a critical point where they have less than 3 months of antiretrovirals available. So it's a double-edged sword. Multi-month prescription is so important, but on the long haul, we have to ensure that the stocks are replenished and replenished in a way that everybody can have access to antiretrovirals. But there is another silver lining. We've seen that HIV self-testing policies have taken up, and with the 10 additional countries happening to pick up this approach since COVID started. And I think that's good because countries are noting that they need to continue with testing and they need to be able to link and get people living with HIV the therapies that they need. So what are countries asking us for? Because many, like you, many of your colleagues working in the country or working on HIV have been repurposed, I hate that term, but are now working on COVID as well. But to do this safely, they want PPE, they want capacity building, they want to know how to case manage COVID as well as their HIV. They want guidelines, they want to have experiences from other countries, and certainly they want to have a better idea about how to really hold telemedicine effectively. So what is WHO doing overall in terms of trying to mitigate this impact? We have, if you haven't gone to the WHO websites, I encourage you to go because we probably have a guideline on almost anything you could think of, from how to parent your child to really important things, how to reduce interpartner violence. But key are documents around surveillance, clinical care, laboratory needs, as well as logistics and how to continue to shore up the essential medicines. For example, this is a clinical management guideline that gets updated every 2 weeks. And here we have a section that is focused on people with comorbidities, including HIV. Currently, right now, we're not in a position to recommend any particular antiretroviral or other treatment, but soon the group is going to be meeting this week or next to review some of the new evidence coming out of the recent trials on dexamethasone. We have developed a set of guidance on maintaining essential health services, and this brings it together in terms of community action as well as facility-based actions, and divides it into practical operational strategies for maintaining, such as what does a healthcare worker need to do, what does the flow of a health system look like, to actual specifics around diseases, which are the essential services for HIV that can be maintained, and which are those that could be postponed or have catch-up when we're in a better situation with the pandemic. So, for example, here are some of the essential services that we've put into that document. Certainly, we feel that under prevention and sexual health services, we need to maintain condoms, harm reduction, self-testing, contraception, and PEP and PrEP. Whereas VMMC, we feel we can pause until another moment. For testing, we're really promoting differential HIV testing and including self-testing and using facility pickup in the community online platforms for discussions, and pharmacies' mail-in vending machines. And now this group working on self-testing is moving into the COVID era, and they're going to be working on self-testing approaches for some of the COVID tests that are either antigen or antibody specific. We are looking at, of course, like all partners, continuing with our multi-month prescription, but not just for antiretrovirals. We really want to focus on OST, TPT, and other critical medicines for people living with HIV. And here's a great example, which I love, from Pakistan, where really the community has developed an approach all on their own and didn't need help. And this was something that is really inspiring to see how community has developed these approaches. Like Angeli, we're also very worried about the dual stigma of both COVID and HIV. And so it's quite important that we see that the key population services continue, especially harm reduction. We have put out and are also very focused on persons who are in prisons and other closed settings, because during this time, it's quite important to identify ways that people living with HIV and others can be in non-custodial situations so that they are not at risk by being in an overpopulated system. Lastly, we've been working quite a bit on diagnostics. We have a diagnostics consortium that's really looking at what are the opportunities within country to bring tests at much lower prices, to have them distributed to all low and middle income countries and island states, and to bring on new technologies as they become available. One thing we did early on is we said that early infant diagnosis of viral load and viral load testing for children as well needs to be maintained, and that we did not recommend centralizing any of the testing platforms, because that certainly would bring us back decades on terms of being able to get both HIV testing and TB testing in the communities. So going to research and science, WHO has spent a lot of time in this area. It started with the Solidarity trial, but then it's moved to the Solidarity serologic and surveillance studies. We have accelerating vaccines. We are using big data and have systematic reviews that are going on regularly, live reviews. So I encourage you all to go to our websites and see if you can find something where all the data can be found and that are collated every day. There's also the ACT Accelerator, which has 4 pillars to develop tests, treatments, and vaccines for COVID, and under an overarching umbrella of resilient health systems, and with a very strong community link to this. And we believe that with this ACT Accelerator, there has been quite a bit of donations, that we are preparing the terrain for when a vaccine or when a very effective treatment becomes available, we can effectively get these treatments out to the communities that need them most. Lastly, WHO has been spending quite a bit of time on combating the infodemic, training healthcare workers, and providing information for all audiences. So I think if you go to our website, you'll see that all of the training on doffing and donning PPE can be found in every single language, and you can find an audience that's for you. Are you a family member? Are you a healthcare worker? And so how can we be better at providing the best information to people out there who need it the most? Lastly, I'd like to end with the fact that we're supporting community and civil society engagement along with all of our other stakeholders. And we know from the HIV experience that if we don't engage community early, and if we don't have buy-in, and if we don't have a commitment from community, we're not going to do well in this pandemic. We've seen it with HIV, we've seen it with Ebola, and certainly we're seeing it now with COVID-19, that we need to have buy-in, and that's something that WHO with its partners is really working towards. So we know that HIV gains are at risk during COVID-19. We know which essential services need to be maintained, and we're working with our partners to restart these safely as possible. And we can use DSD models, community pickups, e-health, m-health, and strong community engagement to really restart this. And we believe with all the other wraparounds that are occurring, we'll be able to prepare the terrain to build back better. But we need to do this not with just words, but with actions. And WHO is committing, I would have to say, all of our staff, at least 90% of our staff or more, are working on COVID, as well as their other day jobs. So with this, I'd like to turn back to José, and thank you very much for the opportunity to speak. Thank you.
Thank you very much, Meg. Thank you for speaking to the innovations that are being implemented on the ground in so many countries to ensure continuity of care, as clearly PEPFAR is doing as well. I'd like to introduce our last speaker, Dr. Shannon, who's Deputy Executive Director for Program at UNAIDS. She will review UNAIDS COVID-19 response, including the importance of applying lessons learned from the HIV response and leveraging the investments made over so many years that have led to so much progress that is now jeopardized, but we're trying to mitigate. Shannon?
Great, thank you. Let me just start by echoing the thanks that Angeli and Meg shared. Thanks to IAPAC and ITPC for organizing, but also thanks to not just IAPAC and IPTC, but certainly PEPFAR and WHO and many other partners that we're in constant contact to try to learn from each other, fill in the gaps together and problem solve. And so that's a little bit of what I'll talk about here today. So I think about really three areas here when we talk about UNAIDS and what we're doing with COVID-19. Certainly, it's about listening to people and engaging communities to finding out what people say they need and then helping to problem solve to get it. Second, it's absolutely about HIV service continuity. But third, and cross-cutting, I think, it's really also about applying lessons and investments from the HIV response to an effective COVID response. And that includes really looking at community-led responses for HIV and key populations, but also for COVID, and really taking a multi-sectoral approach, complementing a lot of the health information that Meg shared, and really drilling down on the human rights, the social and the economic supports as well. Meg mentioned the modeling that was done, and we always sort of have to start by saying, well, how bad could it really be? Bad. It could be really, really bad, which is why we do these models to say how much importance do we need to place? How much problem solving and attention do we need to galvanize on making sure HIV services aren't disrupted during this time? And it's huge. As Meg said, a 6-month interruption of HIV treatment services in sub-Saharan Africa alone would take sub-Saharan Africa back to 2008 death rates. We can't lose more than a decade in just 1 year, and that's in 1 year alone. So not surprising, but surprising. It really emphasizes what we need to make sure to not let happen. Likewise, we know that lockdowns and border closures are impacting both productions of ARVs and their distribution, potentially leading to increase in costs and supply issues. Fortunately, we are working closely with Global Fund and PEPFAR and WHO and UNICEF to not let these things happen accidentally, to keep our eye on where the shortages are, make plans and solve problems, both at the production and transport level, but also on the ground. But there are so many places where this can go wrong. And I think we want to raise the alert that even when we're through the most intense COVID times, we will need to keep watching this during recovery and post-COVID recovery. We can't take our eyes off the ball to make sure that we're doing everything we can together to ensure continuity of HIV commodities and making sure that their affordability sticks. And so, sort of step number one when COVID really started spreading, was to understand what do people need. Now, I think we could maybe think we knew or predict what people living with HIV and members of key and vulnerable populations might need, but we really believe in asking people themselves. And so we've partnered with networks, community-led networks of people who live with HIV and key populations all around the world to really ask, what do you need? What do you need in terms of COVID-19 information? What do you need in terms of COVID-19 prevention tools? What do you need in terms of HIV continuation of your services? What do you need for social supports, income supports, and mental health supports? And, what we found is two things always rose to the top immediately. People living with HIV wanted to know, what do I need to know about COVID? So COVID information that was digestible and usable. And the first thing that rose to the top for people living with HIV, in addition to that, was I'm worried I'm going to run out of my medications. Now, as these lockdowns continued, as more countries came aboard, we also started seeing and hearing a lot more worries about my income, my ability to feed my families, and worries particularly among key population members about their safety and human rights abuses. And so some of these responses start as really simple. How do we work with WHO and others to make some simple, digestible, what do we know about COVID-19 right now tools that are widely available, but then can be updated as we learn more, as new studies like the Cape Town study come out. And these sort of tools have been translated into many different languages and are available all over. But also then started to really jump into together, what do we do about HIV service continuation, in particular, HIV treatment. One of the first tactics that we all banded together on was multi-month dispensing, with this idea that if someone has more of their own drug in their hands during lockdowns, during transport issues, during overrun clinics, this gives them more tools to work with. And Meg already mentioned there have been tremendous progress, and there's been progress even since COVID in implementing policies on multi-month dispensing. But when we looked country to country, there was a vast difference between the availability of the policies and really what proportion of people under treatment were benefiting from that policy. We're getting 3 months or more of their prescriptions routinely. And there's a lot of barriers to actually getting there. And multi-month dispensing doesn't stand alone. As Meg mentioned, we're all working, and Angeli mentioned as well, these other flexibilities, community pickup and dispensing, home delivery, allowing someone to pick up your meds for you. Fortunately, we have seen tremendous progress during COVID on moving much further to implementation. But it's not always one directional, as Meg said. It has to be monitored to make sure it doesn't move backward. And I think we all want to understand these gains in implementation. How do we make sure we sustain them after COVID as well? How do we make sure to continue to get people what they need, how they need it in the most convenient way possible? So in addition to looking at differentiated service delivery, community-led delivery, self-testing, harm reduction, we've been putting out additional guidance that are tools of the trade for how to continue services for HIV-affected populations, whether it is specifically for key population-focused programs that we did in conjunction with Global Prevention Coalition and WHO, and really built off of some PEPFAR-funded key population programs, to how to maintain prevention, condoms, all these other tools during the time of COVID as well. And as we've heard throughout today, and I hope everybody here has seen with their own eyes, the resilience and innovation of community-led players to make plans that are serving people. We have examples all over the world that are incredibly widespread. This is just one example of local service taking it into their own hands to make sure people were getting what they needed. But also beyond service delivery alone, what are some of the lessons learned to build off of for the COVID response? Angeli referenced a lot of the infrastructure and platforms that are already being leveraged for service delivery. But we know that together collectively, we've learned a lot more that also translates to combating an epidemic. And one of the first things we did is we got together with our Human Rights Advisory Council and said, what are your top recommendations for the COVID response? And this sort of document, how to have rights in an epidemic. We found early on, especially, there was a lot of discussion when public health responses for COVID were being talked about of like, oh, well, it's a trade-off. It's a trade-off between a public health response and human rights, and we're just going to have to live with it. And we're like, okay, so we know from HIV that the most effective public health response that gets to the end game is also a rights-based and community-led response. They're not in conflict at all. And in fact, you can have restrictions on people, that are rights-based. They have to be evidence-based, time-limited, proportional, and ideally non-criminalized and non-inflexible and non-resulting in severe punishments. So this is one of the many topics, human rights, where we've taken the lessons learned with HIV and put up some guidance for COVID as well. Also on how to support women and girls, also lessons from HIV prevention, and also starting to move into both the lessons learned and recommendations, but also the political voice and advocacy for people who are being severely affected under COVID. And this really comes back to the human rights and community-led engagement. We've worked with partners and leaders from across the world to put out statements and tools, adding political voice to sex workers, to people in the LGBTQI population, to prisoners, for migrants. We are working with partners to identify and respond to in-country human rights abuses. And soon to come out, we've implemented some monitoring systems to really monitor in a number of countries the use of these human rights principles under the COVID response to really accomplish more and then the abuses that go with them. We've also made the call that community-led organizations that are so important for governance, for community service delivery, for monitoring what's really happening on the ground, need to be considered for being deemed essential service providers. We've seen in a number of countries where community-led organizations want to and could be providing the kind of innovations we've cited, but are barred from their offices or barred from getting out of the house because they weren't considered essential providers. This is starting to change. And certainly we're also working on the issue of access to medicines for COVID, working with the Partnership to Accelerate COVID-19 Testing by Africa CDC, but also working on a call for a people's vaccine. You know, really this idea that as tools and technologies to combat COVID are developed, that we want to make sure that people have access to them, that they're distributed, that they're available based on need, not just based on wealth. And so making sure, particularly as these first tools are under production that are scarce compared to the need, we can look in solidarity as a world and say, great, how do we make sure they get to the people who need them most right now? And then finally, we really take seriously trying to be an advocate and a player within the United Nations family itself to continue to bring these lessons we've all learned together in the HIV response into the UN mobilization also. At a global level, we're part of the Secretary General's task team on the immediate social and economic responses to COVID-19. And I think, you know, working with partners, this really is where the HIV perspective was able to put into this formal document and this approach, this idea that community-led infrastructure are part of the investments for resilient communities, that should be seen as part and parcel of building resilient communities and in a resilient response, is fighting for community-led organizations to be at the table for governance and decision-making, to be part of service delivery, to be part of monitoring and accountability. And when it comes to the field, we are working with our UN sister and brother agencies to really try to deliver. WHO is providing such the strong health leadership across the world, and we are lined up behind WHO for that to happen. We also find at country levels that oftentimes there's a need to pull in the rest of the agencies that are non-health agencies in the non-health multi-sectoral mobilization for the collective response. We are continuing to fight for community organizations to have seats at the table for COVID planning and COVID decision-making. And I have to tell you, this is probably the one where we're still struggling the most to make sure it's not just scientists and doctors and economists and experts at the table, but we have community members and community networks and community organizations who can be a voice, not just in the whether to make a decision, but the how to implement it in the way for greatest good to all of the people who need to benefit. So with that, I'll just say thank you very much. And thanks. I know that so many people who are online today are part of these COVID responses that we are describing. And thanks for your dedication and for your work. And I'm learning from you. Jose, thank you.
Thank you very, very much, Shannon. Unfortunately, we're out of time for questions, but I want to thank our panelists for their superb presentations, for all they're doing to ensure continuity of HIV care globally. And of course, we want to express our solidarity with all of you who are living through and working through this COVID-19 pandemic. Help spread the word. Let's wear a mask, let's social distance, and let's wash our hands. Thank you, everyone. Stay